Welcome to a new discussion with Dr. Michael Ellis. In our webinar today, we'll be covering unique perspective of an orthodontist who's very interested in sleep and breathing and various other topics like education, training, patient outreach, reducing the barriers to getting started, and the kind of lessons he's learned along the way. I'm Dr. Steve Carstensen, Chief Dental Editor of Dental Sleep Practice, a Medmark publication. Before we get started, I would like to invite viewers to use the chat box on the right side of your screen to ask any questions. We'll be weaving those questions in through Dr. Ellis's presentation today. Now let me introduce you to Dr. Michael Ellis. He received a Bachelor of Science in Biology and Biochemistry, along with a Bachelor of Arts in Chemistry. Arts in Chemistry, I got to talk to you about that one, Michael, from Virginia Tech. He earned his Doctor of Dental Surgery from Virginia Commonwealth University Medical College, specialty degree in Orthodontics and Dentofacial Orthopedics from the University of Missouri in Kansas City. Dr. Ellis has been featured as one of America's top dentists in Washingtonian Magazine, Northern Virginia Magazine, and Virginia Living Magazine. He's a member of the Spear Study Club, the Millennium Society, and the Seattle Study Club. Also lectures to numerous study clubs in Northern Virginia on dental sleep medicine, surgical orthodontics, treatment of patients with missing teeth, and multidisciplinary care. So I'm really looking forward to hearing from Dr. Ellis today about how you can make sure orthodontics is an important part of your dental sleep practice, and in general, how you can make that a successful part of your community health. So welcome, Dr. Ellis.
Thank you very much for having me. I appreciate it. Very nice to see everybody today.
Yeah, I'm curious, how did you get started with dental sleep? We saw your training. So tell us about Bachelor of Arts in Chemistry. That's arts in chemistry. That's interesting.
So when I decided to go to college, I knew I've wanted to be an orthodontist since I was 12 years old. So when it was time to go to college, I decided to head to college with the ability to pick up the electives in the other area. And I loved chemistry. My 11th grade chemistry teacher really kind of sparked the sciences in me. So I decided to go, and the Bachelor of Arts program allowed me enough free electives to pick up all the biology and biochemistry while I was down there. And as I was doing it, I ended up taking so many other courses that I realized, hey, I also have enough credits to be able to get a Bachelor of Science in Biochem and a Bachelor of Science in Biochemistry. So, in chemistry, biology. So ended up the 3 degrees and moved on to bigger and better things.
Wow. So after orthodontic school, what happened?
So when I finished ortho, my parents being military, ended up in the Northern Virginia area. It's where I graduated high school, and I knew I was going to be coming back here. My wife's family's here. They're there here as well, and I wanted to return to a community that I was very familiar with. And so that's where I came back from Kansas City, came back to the Northern Virginia area and set up private practice, buying a practice from a well-respected and established doc, and kind of started to build my own brand and my own process. And then, as I went through orthodontics, and I've now been practicing almost 18 years, you want new challenges in life. Orthodontics I love. It's my first passion. It's my first love. But, as you do stuff long enough, you want new things in your life, and dental sleep medicine came into my life, and that became a secondary passion for me, and that became an addition to my practice about 5-6 years ago, and continues to grow.
So how did that come into your orthodontic life? Because orthodontists, are pretty traditional in general ways. I know how I was not trained. Trained in dental school. So tell me about how that started for you.
Well, dental sleep medicine kind of came into my life more from a personal experience myself. Obviously, I'm not a teeny tiny twiggy kind of guy. I'm kind of the poster child for obstructive sleep apnea with a bigger body type and everything. And through most of my life, I've always suffered with snoring and stuff like that. My wife loved that dearly, and it actually was about 7 years ago, right around Thanksgiving, my body, I think, finally said, no, we're not going to put up with what you're putting us through at night anymore. And I started actually having medical problems that put me in emergency rooms, urgent care facilities, and even my primary care physician. And through numerous doctors that saw me, took tests, said I was fit as a fiddle. Nobody ever asked me, well, how are you sleeping? What's going on when all of the stuff that was happening to me was happening to me as I was going to sleep. And while I was sleeping, nobody ever asked me. They continue to put me on medication after medication after medication, and it wasn't fixing the problem. And I ended up going to one of my Millennium Society meetings that was being given by a board certified sleep physician, all about obstructive sleep apnea. And for 2 hours, I sat there and felt like I watched the story of my life. Every problem that I watched on the screen, every risk factor, I had almost every single one of them. And so I went and saw that. I met the doc after the lecture, and I said, when are you in your office again? He said, come by at 7 o'clock the next morning. I showed up. We went through the testing. He ended up diagnosing me with obstructive sleep apnea and started treating me, in my case, with a CPAP. And all of a sudden, my problems started going away. Didn't have the issues at night, came off all the medications, lost a lot of weight. And all of a sudden, my brain kind of said, holy cow, it was the answer to all my problems. And so I started to kind of look into the field, and I found out that there was a huge dental component of the whole thing. And as I continued to explore the field and looked at it and saw what was going on, I started noticing that patients were coming into my practice that were struggling with sleep apnea or had sleep appliances that were causing them problems and were having to go into orthodontic retreatment. And all of a sudden it became very obvious to me that, I was put on this pathway to have these problems, to learn about this and add this to my practice. And I realized that it's something that not only was I passionate about, but I was fully prepared to be able to do something about. And so that's where it all started. The next steps I took were how to educate myself and train. And I've always been, clearly with my educational background, like I'm one to want to take the classes before I start doing. And so I started the educational process and training myself. And that's kind of how I got into it.
So, well, clearly, I'm going to state the obvious here. You're orthodontic and what is it? Orthodontics and Dentofacial Orthopedics. At the time in Kansas City, didn't offer anything about airway structure and how it could affect sleep. So, how did you get your training then?
So when I started looking into a bunch of different programs, there were programs all over the country. Some of them as fast as a weekend course. Some of them talked about 3 to 4 months of training. Early in my career, as I brought in consultants so that I could learn, they don't teach you business in dental school. We all know that. Some people are more gifted with just their natural stuff. I read a lot of books and made a lot of mistakes, and I work with consultants along the way. And every consultant that I work with along the way had the belief of long-term training, that you can't fix something, you can't learn something in 3 days, and even 3 months. So most of the consultant groups that I worked with in the past were 12 months, 18 months. And so when I started looking at what was out there, I came across a company at the time, was Dream Sleep. And Dream Sleep offered a long-term process. It offered a lot of different components to their training program, training the staff, training the doctors, continuing to be there as we grew and developed. But more importantly, they also provided a pathway through the ACSDD, which is basically known as the Academy, of a number of training modules that took you through all the continuing education, to be able to get up to speed on this whole thing. And I believe that if I'm going to do something as life changing as what sleep did for me, I want to do it right. I want to understand why I'm doing what I'm doing. So with the ACSDD, they provide a pathway for you actually to become certified as a sleep dental specialist, which is a lot of hours of continuing education with a lot of articles, and at the end, a very comprehensive test that you need to perform at. And at the end of that, you become certified. And then they also provide pathways to actually become board certified. And The thing that I loved about their program and what really drew me to it was it was a dual MD NDDS program. The board is made up of doctors and dentists.
Oh,
And that's the real component of this whole thing is obstructive sleep apnea is not just a dental problem. It's not a medical problem. It's something that needs to work between the two. And the ACSDD really they provided that, and that really kind of drew to me. Their process of getting you to board certified really tests you as a clinician before they give you that title. And so I went through the pathway. I became a fellow. I eventually became a full board certified sleep physician, which is where I'm at right now. And I'm actually in the process of starting to do a second board certification through the AADSM, which is the dental branch of dental sleep medicine.
right.
So
So how long does that process take? If a dentist who, you know, say you were starting over, you were convicted of your problems and you want to learn more, and so you call up a CSDD or dental sleep or dream sleep and go, okay, I want to start. How long does that take?
I think it's a little bit different for everybody. The module system, again, it's a lot of articles and a lot of videos. And the reality is, if you really want to sit down and push yourself and plow through it, you can get through it in a month or so, and get yourself prepared. I personally, being that I've got two kids and a busy practice and everything, didn't have the ability to lock my doors to the world and go full immersion in the process. But I think to each their own. If you want to push yourself, you can get through the process quickly. As far as actually getting board certified and fellow certified, that does take some more time. The thing that I love about the ACSDD is in order to get fellow status and board certified status, you actually have to treat patients with appliances with before and after testing to show that you know how to diagnose, you know how to deliver an appliance, you know how to titrate an appliance, and make sure that then you test to show that you've actually accomplished something. And to get there, to get full board certified, I had to successfully treat to board certification 20 patients of varying levels, with different processes to be able to do that. And then you actually have to submit that to a panel of dentists and physicians that are already board certified for review. It was an amazing learning experience. So if you have a humongous, wealth of patients that you have access to, you may get through that faster than others. For me, it was a learning journey. I wasn't in a rush to get through it as fast as I could. I wanted to make sure that I was learning what I was doing.
Yeah, that sounds like a reasonable plan there. So you Netflix binge watch the videos, but it takes a while to put that into action. And putting it into actions, I know from my experience, that's where we really learn, is when we take that, even the book learning or the reading learning or the video learning, and putting into clinical practice and solving the clinical puzzles that sit in our chairs.
Absolutely.
So was your experience, your board patient training different because you're an orthodontist?
Well,
How did you?
the other part that got me into this process, other than my own medical experiences, I saw a lot of patients coming into my practice that were seeking retreatment for orthodontic problems that stemmed from sleep appliances that were made by physicians that maybe did or did not really understand what they were doing. When you're positioning jaws, when you're holding jaws forward and stuff, there are risk factors to that whole thing. Movement of teeth, um, loss of capturing of the joint. You can cause TMJ problems. You can cause muscle fatigue. You can cause the muscles to get confused. And if you don't design appliances correctly and educate the patient of the risks and how to recapture everything, they can have issues. And I started seeing those issues in my practice, which was another reason why I really wanted to get into this, because I wanted to do the best that I could for my patients. It's why I took my time going through the clinical training to make sure that I learned how to do that, and it's still a challenge to this day. Appliance selection, I would probably say, is one of the hardest things for the clinician to do. Figure out what appliance is right for the patient. There's over 150 appliances out there, and that number continues to grow all the time because they're always looking for a different way to fix the problem of this appliance that already came out. So that's a huge challenge, and that only comes with clinical time. It's why I believe that the process shouldn't be something that you rush through, because in my opinion, board certification should mean something. It really truly should.
Yeah. So yeah, knowledge without action is just a hobby. So you put it into clinical work, and you pay attention, and then we have wisdom.
Absolutely.
And that's what that's the process I hear from you, is you're developing that clinical wisdom, and so you can pass a board exam.
Yep, absolutely. The other thing that I really learned is dentists can't fix every case. There are patients that doesn't matter what appliance you make for them, they're going to be a CPAP patient for successful treatment of their sleep apnea.
Mhm.
And I still feel like I'm learning how to identify those patients. I think my biggest passion going forward is if I can before it's all said and done leave one thing on the sleep world. I hope to accomplish the ability to help a clinician understand this is a sleep patient that can be dealt with dentally, and this is one that really needs to be back to the MD for whether it's Inspire, whether it's surgical, whether it's CPAP, a more medical based treatment.
Mhm.
And that's something that's still being figured out in this sleep world right now.
Yeah, I think that's a very true statement. Most physicians are trained to treat, with physician tools, CPAP mostly, a
Yeah.
little bit of surgery, and then and they don't always think all the time about the other things. Just like your doctors, early when you were describing your medical issues, didn't ask you about sleep. Oftentimes, sleep physicians forget to ask about other options as well.
Yep.
Yeah,
Like they say, when all you have is a hammer, the world's full of nails. So
that's true. True that.
um,
Yeah, we
I
can't.
think
Thankfully, the physicians that are working with ACSDD, the ones on the board, they're clearly interested in cross treatment, and that's what dental sleep practices physicians certainly are as well. So I'm my circles, I guess, are slanted a little bit towards physicians who are interested in working together to solve the problem.
yeah. Well, that's the one thing Dream Sleep is doing a great job helping me with is as we work through marketing strategies and everything and start to talk to sleep physician offices is they're really focused on helping to open the eyes of the medical physicians that there are other things out there. And my general experience so far is it's not so much that they don't want to work with dentists, it's that they didn't know that we could help. And unfortunately, dentists haven't always done things right, and that's kind of jaded some folks to want to work with us. And so it's a little bit on us to show that look, we're trying to do this the right way, and that's why we're trying to make sure that we don't rush through, that we sit there and we can show, look, we're doing this the right way. We want to work with you, and we want to build this correctly.
So does Dream Sleep give you some tools to communicate? I mean, I'm thinking about a dentist who, is in a new community for them, and they're starting this new service. How do they have tools from Dream Sleep to reach out to local physicians? Your primary care didn't ask you about sleep, so how would Sally's primary care learn about sleep?
Well, the dream sleep process that they work through, their doctor referral program, which is one of the components. They offer everything from training to clinical to but they even go into the world of marketing. And the cool thing about them is you can choose to add as much to your practice as you want or not. It doesn't have to be an all or nothing type approach.
Right.
But when they do it, they have a process that they go through to build physicians that are likely to do sleep in their practice. They build that list based on searching websites. They reach out to members of those offices to say, would there be any interest? Dr. Sirkin, who is a board certified sleep medicine specialist and cardiologist, goes so far as to reach out personally on offices that do show interest to to talk about how what we're doing is different and to give that medical support to build that confidence. And he sticks with you through the whole process. And then the goal is hopefully to open the door to whether do lunch and learns or come by, meet the doctor, sit down, and just tell what we do. It's a slow process, but it's a process, and it's one that they've shown success with, and it can work.
Dr. Lee Serkin, viewers, is the chief medical editor of Dental Sleep Practice magazine as well. He's a cardiologist, and years ago began a new organization about cardiologists and sleep, and invited dentists straight away. I've been at every meeting they've had, and he's been a friend of dentistry ever since he got into sleep. And so to hear that he reaches out on behalf of a dentist who's interested in doing this to that dentist area physicians, that's a powerful help to get your practice going in a collaborative way.
He's been he was somebody that I met at one of the dental sleep medicine meetings that was a dual DDS MD. Um, we kind of hit it off because we're both baseball fans. Went and saw a Diamondbacks game while we were out there. But he's been a friend, a mentor. He's been there to help me with questions, to help understand the medical side. He truly. I meet very few people that have as much passion to attack this problem and forge that bridge between medical and dental, and he's very committed to it.
Yeah, that's what we really need. Like you said, it's we get in our silos. Your physicians didn't know to ask you about sleep. You stumbled across it a little bit because you didn't know anything about it from your training. So both areas of medicine were in similar circumstances, and now we have intentional bridging of that gap between physicians and dentists by people that are passionate about it.
I totally agree.
Yeah, yeah, because that's the only way to do this. As you said, not every patient can be treated with a dental appliance. Certainly, not every patient can be treated with a CPAP because there's too many people that just won't use them. And so we have to work together if we're going to solve this problem. Yeah,
Okay.
yeah. So a dentist in practice interested in doing this looks around, and how would they know, what their potential is in their practice?
Well, I think every dentist, even the ADA, a number of years ago, I think it was 2017 or
17.
18. Yeah, they deemed that screening for sleep apnea should be a standard of care component of every dental professional. So whether a dentist wants to actually get into treating dental sleep medicine versus actively screening, identifying the patients, and finding people like myself or other dentists in the community that are doing dental sleep medicine training, I think that's the first step. Identify whether or not you really want to get yourself into this. If it's something that you say, yeah, this seems interesting to me, obviously then you go through the training components of the whole thing. The reality is we all know the statistics. There are probably 40 million patients out there walking around with undiagnosed sleep apnea. And, the United States in general we're not a thin nation. We're not a, athletic nation. So I don't think that number is going to decrease with time. Obstructive sleep apnea is likely the gateway disorder to so many things that degrade the quality of our life later in life. And so, this is something that you're not helping a patient. You're adding years to their life, and you're adding quality of life at the end of their life. And when you're talking about 20% of the population, that's a lot of patients that sit in your chair every single day. So you know, it's like anything. I don't think that this is a specialist only thing. It shouldn't just be an orthodontist treat. There's too many patients. We need to do it, but you got to find out whether or not you want to do it, and then kind of go from there.
You mentioned that you treat patients who had been given oral appliances by dentists, and now they're something's wrong. They
Mhm.
have a jaw joint problem, they have a bite problem, and you're retreating them. So, do you feel like the training that How would a dentist ensure that you're not going to be the next dentist causing those kind of problems?
Well, things, the problems that I've in general seen is appliances that don't provide proper coverage.
Mhm.
So thus they don't cover enough of the teeth in order to be able to hold them in position. Um, that causes movement of the teeth. That causes patients to end up with flaring of teeth in different situations, which is a lot of the reasons why they work their way into my office with regards to my teeth aren't straight anymore. Again, it is a risk even with a properly designed appliance, but there are things that you can do in order to be able to mitigate that or at least minimize it as much as possible. Orthodontists, I think, in general, because we move stuff around all the time, and then we got to figure out how to retain it afterwards. We do understand retention, and I think that is something that you know just our profession in general is kind of geared towards being able to keep things in place once you finish moving things around. So that was something that I felt fairly confident with when we were going through. The biggest mistake, though, that I see is lack of follow up, and even scarier. Here's your adjustment key, and if you start snoring, go ahead and give it a few more turns. And I've seen a lot of patients that they don't understand what they're doing, and so they over advance their device. They throw the patient completely off the joint. They put the muscles and the pterygoids into total spasm. They don't use AM aligners to recapture bites. These are the kind of things that if you don't explain to a patient why they're doing it, how to do it, and then follow up with them on a 6 month or annual basis to make sure that they're still doing good, by the time something's gone wrong, it's normally gone really wrong, and that's the component that also led a lot of patients into our practice. So those are the kind of things. I think a lot of it's education, and I think it's also protecting a patient from themselves.
So back to the education pathway you talked about, where it's not just a day or a weekend course. It's not. It's a significant amount of training plus a whole lot of paying attention.
Hmm.
Yeah.
Yeah, as you go through that training, they take you through. This is how you screen. This is how you diagnose. This is how you test. This is how you design an appliance, deliver an appliance, titrate an appliance, and most importantly, then this is how you get a patient into recall so that you can continue to make sure that they're good for years and years to come. Like this this is an active on once you deliver an appliance, it's an active ongoing treatment that needs to be monitored. Not
Mhm.
as closely as when you're titrating, but you still need to be there and available for your patients.
So actually, somebody just brought that up. Well, what about testing? That seems to be a big question these days. And so, they're asking about testing patients. And I know you're involved with the Virginia State Board. You mentioned as in our preparation. So tell me about that a little bit.
Well, so testing basically you've got two forms of testing out there. You got your polysomnograms, which are lab based, and then you've got home sleep testing. And there's a lot of back and forth as to which one's better. Is it better to be in a lab with a whole lot of leads attached to you, collecting an infinitely large amount of data, except for you're not in an environment you're used to, you're in a room with somebody watching you? A lot of people wonder whether or not you get a truly good diagnostic sleep that night. First is a home sleep test, which is not going to give you as much data, but you're in an environment that you're comfortable with, and so more likely to have a normal night's sleep. Um, we obviously gravitate towards home sleep testing unless we get weird results on those, in which case we will get a patient over for a polysomnogram. Um, but the home sleep testing, it has become a little bit of a controversial topic as to who gets to order that test. Um, Currently, many of the states in the United States don't have hard, fast rules as to who gets to order them. States like New Jersey and I believe Texas have laws in place that state that a home sleep test can only be ordered by a physician, and that's a statewide law. But the majority of states, not in the medical or dental board based information have any rules and regulations. I personally believe, the one thing that everybody is very clear about is that a dental sleep test must be read by a board certified sleep physician, an MD. We are not. I've looked at sleep tests. I've seen the data. I know how to analyze them. I would never do it in a million years. It's not my place. It's obstructive sleep apnea is a medical condition. Is medical ICD codes. It will it is filed through medical insurance. And so in my opinion, it needs to remain within the realms of medicine from a guidance standpoint of when to test and where to go from there. So the idea that the MD orders the initial sleep test is pretty well accepted across the board. Where it gets a little bit fuzzy is some people believe that once the dental device is delivered, that we should be able to order all the tests afterwards. And that's where the controversy comes in. You can't really create the ability for a dentist to order a sleep test for certain reasons and not other reasons. And as a result, there's been a little bit of an argument with dentists saying we want to be able to order them across the board. I actually went down to the Virginia Board of Dentistry while they were trying to come up with their own rules and regulations and provided insight, in my opinion, on the whole thing. And there were a number of physicians there, and I felt like by the end of the meeting, the compromise that the compromise that I suggested was when a board certified sleep physician orders the first test, if a patient comes back and does have sleep apnea and they order a ability to make a dental sleep appliance, the EO 486 code, they can also order a secondary titration test to be done at the same time. That eliminates the dentist's barrier to be able to test the device that they have delivered and allow them to continue on with their treatment without having to run down a physician to ask for permission on everything. And the medical community seemed very open to that idea. They said, okay, we still have control to order the test, but at the same time, we understand the problem and the need that you have as the dental community. And again, when you put these docs in a room and you let everybody talk, these are the compromises that we can all get to. And I think it can move things forward. I'm hoping that that is the direction that the profession goes.
Yeah. I'll remind the viewers that American Academy of Dental Sleep Medicine at aadsm.org has a up-to-date interactive map of your state's rules and regulations. Like Michael said, most states are silent on this issue. Some states have very strict rules, Georgia, Texas, New Jersey, New York, but a whole lot of states have just not made any ruling at all. So, of course, Medmark Media and Dental Sleep Practice Magazine urges you to check with your state board if you have any questions. But that map is up to date from adsm.org. And so check there, and it's very helpful because it is a state of flux where there's a lot of us in medicine and dentistry not really sure what the rules are these days, what the best way forward. I applaud you for going and making a case for dentists to be involved because just a bit about my soapbox here is that, you mentioned 29 to 40 million Americans have a breathing disorder. There's not enough sleep physicians like Dr. Sirkin to make enough diagnoses. And so what if we had a bunch of dentists? I was involved with the ADAs. I am still involved with the ADA effort for breathing issues. I'm the consultant to the ADA for these things. And so I want to energize all 190,000 of us to be part of that medical awareness team. So folks like you, Michael, don't have to go to physicians and not be asked about sleep. They should be asked about it by their dentist.
Yeah.
And so if we can put some objective testing in on that in a healthy, safe way, now we can start to move the needle on that number, those millions of people that need some help.
Absolutely. Yeah. It's, I remember seeing the statistics of if every patient that had obstructive sleep apnea had to go see a board certified sleep physician, those sleep physicians would be seeing 200,000 to 300,000 patients a year in order to, it's not possible. Um, dentists, we've got the position laying in the chair in the proper position, you know, to be able to check this out and hear their breathing. Like it couldn't get any better.
Right.
It's such an opportunity for the two professions to finally mend some of the past and come to a place where we truly can help these patients.
And we're being assisted by technology too, because the physicians were trained with PSGs, like you mentioned, which are complicated. People don't want to go to PSGs. They cost thousands of dollars to these
Yeah.
things. And the insurance companies are pushing people into the home sleep test. And the home sleep test market is getting better because it's getting cheaper, faster, and easier to get good data.
Yep.
You can get all the data you need now out of a ring or a fingertip
Yep.
probe. It's
It,
amazing what they can do these days. Yeah.
in my short time in sleep, we've gone from devices on the forehead to devices around the waist to devices on the finger, and yet we're getting, and being that I've had multiple devices, anytime a new device came along, I of course was skeptical. So we got a few patients that agreed to take multiple tests just so that we could see if the numbers were coming back the same. And in most cases, they really were. They were coming back close.
Enough for guidance, with as we learn about night to night variability and understand that, no test is accurate. No test on a Tuesday is accurate for every other day.
Right.
So there's no machine currently that's 100% accurate every night anyway.
Right.
Right? So we just we get clinical guides. Back to the point about knowledge and clinical wisdom. So it takes smart thinking to be able to interpret how a patient is responding to your therapy.
Yeah. Well, and also, as you do this long enough, you start kind of knowing when you see a test that you're like, we've had good nights of sleep and bad nights of sleep. It doesn't matter what you're doing, and it's funny, even on a device that's as non-invasive as taping something to your finger. It's weird that when a patient puts it on, it's like, oh my God, I'm taking a test tonight, and they'll sleep differently. It's why, we normally do 2 to 3 night studies, because in general, you'll see some variability between those nights as a patient gets used to having something on them to get more accurate data with regards to what their true sleep component is. And that makes a huge difference to be able to decide, what you're dealing with. Am I dealing with a mild patient, a moderate patient, a severe patient? What's actually going on with this patient?
So let's pivot a little bit and expand on that, because now we're talking about using technology. So that technology has to come from someplace. We've had a lot of education to be able to do that. We have to correspond with physicians and think about patients. All that takes money. So how do we get paid for all of this? And isn't that one of the barriers that gets in the way of a lot of dentists accepting this?
Yeah, in general, you know, money is a big factor on both sides. You have to you have to get paid for your time. The patient has to be able to afford the treatment that you're offering. In general, you're not going to get any dental coverage of a dental sleep appliance. It is a medical ICD code. So dentists that are adding this to their practice, that are not adding a third party biller or figuring out how to bill with the medical insurance, are going to be doing this on a purely fee for service situation.
Hmm.
Lab fees for a properly made, a good appliance can be $300 to $650, and so most dentists, for the fact that you're going to have an exam, a sleep test, a consult, some records, an appliance delivery, and some adjustments, if you're doing that on a fee for service basis, you're going to have to charge a decent fee in order to be able to compensate yourself for the chair time. We all know that patients don't do stuff because it's expensive. Even though it's right for them health wise, I have never done a sleep consult. I'm almost batting 1,000 that I don't sit there and talk about all the long term medical complications that can come from obstructive sleep apnea. I tell my story all the time. And the patients at the end of it are always like, I want to get tested. I want to find out. When they find out, they want to proceed forward with treatment. And the thing that stops some of them is money, for whatever reason. So part of the reason that we work through Dream Sleep and now are working with another branch of the Dream Sleep brand, which is Nexus. Nexus Billing is that they go through the process of actually getting us the ability to be providers in medical insurance practices. So I, as a dentist, can become a in network for a medical billing code under a medical insurance, and thus the patient is now operating on their deductible and their co-insurance rather than having to come 100% out of pocket. You have the ability, some insurances pay quite well in network. Some of them pay less than ideal. That's insurance. It's the way it is across the board.
Right.
At some point as a clinician, you have to decide that you're doing this because you want to provide something for your patients. And so you're going to get paid better on some than others. And that's life. That's the way it always is. I didn't get into this for the money. I obviously need to pay the bills, and I want to provide for myself, my family. Like, yeah, of course, the money is a piece of it, but that wasn't the driving factor for me. But the biggest barrier to care, like I said, that I find with patients is what's it going to cost me, and how inconvenient is it once I get what I'm doing. That's the reason CPAP. Look, let's be honest. CPAP is the cure for cancer with regards to obstructive sleep apnea. If you wear the CPAP and you get it, it almost works every single time. It is a wonderful treatment modality, but statistics show that less than 10% of the patients actually do it. So if that's the case, then you got to find a way to make a dental appliance that a patient will actually comply with and wear. So, when we got into bill, I've been with multiple different billing companies, pros and cons with different situations, and ultimately, when we settled with Nexus, it was the proper balance of being in network, feeling like everything that I was doing was totally in the right and legal and above board. I felt that their transparency was fantastic, and the process is going really, really well right now. And when patients in situations can sometimes have as low as $100 of their copay or of their deductible to get a sleep appliance, that's a pretty good way to eliminate a barrier of care for patients.
Yeah, that's huge, I think, because as I go around the country and talk to other dentists, that's certainly one of the biggest barriers there is. Back to the fee for service, I do want to say that dentists need to claim a little expertise here, though, because how often does insurance completely cover your orthodontic coverage? How often does insurance, dental insurance, or anything else pay for a set of veneers, or even today a crown and a root canal?
Yep.
So we're used to talking to people about investing their own money in their own health. So and physicians don't do that. So we have that ability to have that conversation. So I don't believe dentists need to let money be as big a barrier. Sometimes they put it up in their heads. But on the other hand, having a very ready assistance through the medical insurance world is now we have two tools, our own
Yep.
spouse plus the other thing. So that's always better, isn't it?
Yeah. It's great when we can sit there and talk to a patient and really explain to them, here are the things that can happen if you don't deal with this. And yes, a lot of patients with great IQs in the medical and dental stuff, when they hear enough pros, they understand that, look, this is money well invested in my health and well-being. But not everybody's in that category. Not everybody's in that position. Some people can have all the heart in the world to want to do something, but if they don't have the financial means, that's where insurance really can help. And that to me, it was a decision that I made, that ultimately I wanted to make sure that we provided the best pathway to give patients as many options as they could to seek care if they wanted to.
Very good, very good. So let's talk about care. So now we have appliances. We're not going to talk about appliances today because, like you said, there's 150 different kinds of appliances. And it takes a lot of training to figure out how to match a patient to the right appliance. But in general, let's you're an orthodontist, so let's talk about orthodontics. So what do you do for adults, and what do you do for kids?
Well, in general, when we all know that sleep patients come in all shapes and sizes. My worst sleep patient ever was 5 feet tall and weighed less than 100 pounds. It doesn't necessarily have to be the big NFL large neck linebacker overweight guy. That's not always the case. But when we look at sleep patients and we look at them as a group and start saying what commonalities do we see with obstructive sleep apnea patients, we see patients that have narrow upper dental arches, lingually tipped lower molars that are crowding the tongue. We see patients that are somewhat retrognathic, lower jaw being back, short lower jaws. We see deep bites. We see clenching, grinding. When you see enough of these things after a while, you start to say, okay, there's probably a component to all of this that maybe if we can influence that to a certain degree, we can put patients in different scenarios going forward. So when I approach my pediatric patients and my kids, again, I understand the AAO white paper and stating that that expansion does not scientifically make a difference, but the more room you provide for the tongue, the more you're able to broaden that upper arch and broaden the lower arch and create a bigger home for that tongue to live in a more forward position, the less it's going to want to live in the back of your throat. And so when we make decisions on kids and we're erring on the sides, we we try to steer away from extractions if at all possible. We try to get in there and do as much broadening of the arches, lower development of the jaw, rather than treatment back to an underdeveloped lower jaw. It's just kind of a when I say that our practice is airway focused, those are the types of things that we're trying to do. And I feel like if I can put kids in a better situation starting, not to say that they may still not get obstructive sleep apnea later on, but at least we're not sitting there going, man, I wish somebody expanded you when you were 8 or had convinced you to wear your rubber bands or done some type of class 2 correction to get your lower jaw forward when you were still growing, because now our only options are surgical, and most patients won't go through surgical options as an adult.
Yeah, that's hard to get them convinced. So, how young do you like to see children?
So, I generally, what I have found is 8 years old tends to be a maturity component. You can get some girls at 7, 7.5. Ultimately, you look at the mouth, you see what's going on, and you see how the kid's doing in the chair. I don't ever want to be the first bad experience that creates the dental phobe for the rest of their life. We got rid of impressions in our practice because it was a bad experience for kids. There was a lot of things that we have tried to do to promote good experiences for children when they're young so that we can start to foster less of the fear of the dentist going on. So we really try to focus on stuff like that, things that don't scare kids, things that don't make for awful experiences. But I love to, when kids need to be expanded, it is so much easier to do it when their upper jaw is soft, the midline suture is open, and you can get in there and just expand, and it's a pain-free process on kids. So 7, 8 years old is great for phase 1 treatment. After that, then it really comes down to what's going on dental age and where they're growing as to when they have their comprehensive orthodontics. We also, as you said at the beginning, I lecture on surgical orthodontics. I do a lot more surgery than a lot of folks. Surgery doesn't scare me. Um, we get really great results. We do a good job being able to explain the benefits to some of our adult patients as to why we're doing what we're doing. And a few of my board cases that I submitted for my board certification actually had no dental sleep appliance whatsoever to get them treated on obstructive sleep apnea. It was orthodontics and jaw surgery.
Oh, good for
So
you.
there's other ways to treat OSA.
We keep cycling back to how much does a dentist have to know to be able to do this well, and so to be able to understand that there is a invasive yet more comprehensive option with orthodontics and orthodontic surgery if necessary. Those are the kinds of things that every dentist need to have on their shelf in order to be able to talk to a patient about their choices. Yeah.
A big reason that I got into a number of, the Seattle Study Club, the Spear Study Club, is because it really promotes multidisciplinary care, working with other specialists, general dentists, and reaching across the different specialties to provide the best care that we possibly can for patients. I think in general for all physicians, the more that we can get them to open their minds to realize that there are treatment options that maybe you can't deliver, but you can put patients in touch with those that can deliver. The more we do that, the better the care we're given to patients.
Right.
And it may not benefit you and your practice financially or anything, but that's not what we're there for. We're there to give the best we can to patients, and so that's kind of how I look at it from the standpoint of sleep. Is there are lots of things that I can't do, but I need to know about them so that when I come across the patients, if I think it's right for them, I can get them to those people.
I'm gonna give you a gentle, a different way of thinking about a phrase you used. You said, you need to know about, the orthodontist and the surgeon, for example, if you're a general dentist. And you said it may not benefit you financially. Well, let's think about that a little differently. Let's think about the general dentist who wants to be a screener, like you talked about, maybe not wanting to do the treatment, but they facilitate a patient getting from unaware to aware and then eventually treated and healthy. That dentist is a hero because they got him off of zero, right? And
Yep.
then and that hero dentist is going to be talked about in that healthy person's circles, their
Yep.
friends, their family, their coworkers.
Yep.
And so how does that not benefit the dentist financially? So if that's the dentist mindset, oh, I can't do this because I'm not going to get paid for making appliances I don't want to do. That's not the right way of thinking. The thinking is let's make the community healthier. That's going to do nothing but benefit my practice. And
Yeah.
so that's a big,
That,
yeah. I know that's what you intended, but just to take that phrase away, you
yeah.
make, yeah,
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 Dr. Mark Raphaelson was the board certified sleep physician that helped diagnose me and gave that presentation to a bunch of dentists.
yeah.
Here he is as an MD coming to give up an evening to speak to a bunch of general dentists and specialists and everything. And that guy will forever, like he ended up selling his practice. He went back to work for the VA to lend his help to vets and everything. But he will always live in my heart as somebody that changed my life. And I
Yeah.
totally agree. We can do that for patients, and that will do nothing but wonderful stuff for our patients and our practice going forward.
Yeah. So you in thinking about this, then when you become a well trained and comprehensive type of a medical provider, then you're going to be connected with other medical providers. If you're a dentist, you're going to connect with physicians and surgeons and ENT doctors, and in your case, pediatric dentists who can handle the 3 and 4 year olds, for example. I know a lot of pediatric dentists who help start expansion at 3 and 4 years old because they
Yeah.
have behavioral training for that. You mentioned that you like to see kids 7 or 8 because they're ready for your treatment, in adults you send them off to the surgeons. By the way, you're helpfully close to one of the best surgeons in the country, Ed Zebovitz, up in Annapolis, Maryland. He's a good friend and just a great surgeon, by the way. Um, anyway, it takes more than just one provider to help these patients, and that's so true across all of dental sleep medicine in general. Yeah, and dentofacial orthopedics.
I totally agree.
Yeah. All right. Well, this has been a wonderful conversation. I hope that people that are watching this are inspired to go and seek out a good education. If you've taken a class at a conference, if you've taken a weekend class. I hope that's gotten you interested in learning more. And go to Nexus, go to the ACSDD, and see what you can learn about being a integrated and wise provider of these services. The rewards are amazing. I've been doing it for 25 years. And so if we think about the impact that all of us as dentists can have working with all of these other healthcare providers, then we can truly have an impact on that, tens of millions of our colleagues, of our patients, of our friends, of our family, of our coworkers that are suffering from unknown reasons because too many providers still don't even know what to see. So thank you, Dr. Ellis, for your time today. Thank you for sharing your story and some very helpful tips for how a dentist can get going on all of this. It's been amazing. I want to draw your attention, viewers, to Dental Sleep Practice Magazine, Orthodontic Practice US, another MedMark publication, and the Nexus systems of helping you become a better provider. It's all there for you to pick up and do your watching and do your cases and gain your wisdom and make as big a difference in your community as Dr. Ellis is doing in his.
Thank you.
Thank you for your time. Any
I
last?
pre- No, I implore everybody to do exactly what you said. Educate themselves, see what's out there, and I'm sure anybody, if they reach out to you guys can put them in touch with me. I'll be more than happy to talk to them. It's something I truly love and love to see as many people get into this field as possible.
As chief dental editor of the magazine, your words are always welcome in print too, Dr. Ellis. And feel free to try out your writing skills. Let me publish something about your story. That'd be fantastic.
We'll get working on that.
Okay, thank you all for being here. Again, I'm Steve Carstensen, chief dental editor of Dental Sleep Practice Magazine, a MedMark publication. And thank you for your time.
All right. Thank you so much, guys.